may I invite the chairpersons on the stage. Dr. Loganathan, consultant, Apollo Chennai. Dr. Mohan Raj, consultant in Narayani Vellore. Dr. Sumati, professor, Kirthi Medical College, Chennai.
I think the entire session went on pancreatic cancer also yesterday. And as more people live longer with pancreatic disease, better the management, I think we are likely to see patients with pancreatic adenocarcinoma, pancreatic carcinoma. May I request Dr. Kirthi Satyakumar, radiologist from Chennai, to give insights on novel imaging techniques to discriminate malignant and benign neoplasms.
This differentiation is important, and oftentimes conventional imaging is just not enough with widely varying sensitivities. Now, currently what is the standard imaging is that we begin with multi-phase contrast enhanced CT, which is the workhorse for pancreatic cancer imaging. Then we do MRI as a problem solving tool, and followed by EUS and FNA. Pancreatic cancer now typically appears as a hypo-enhancing mass relative to the rest of the pancreas. It characteristically causes this double duct sign and vascular encasement and distal atrophy and dilatation of the pancreatic duct. Now, many times features are not so typical and they can be atypical as well. For example, around 10% tumors can be isoattenuating, so we may not see them properly. The tumor may be only in the groove without ductal involvement. Tumor could be diffusely infiltrative or multiple, also creating diagnostic confusion. And when there are calcification and cystic areas, it becomes difficult to differentiate from chronic pancreatitis. So, beyond this, there are benign mimics of pancreatic cancer like mass-forming pancreatitis, focal pancreatitis, groove pancreatitis, autoimmune pancreatitis, to name a few. So with this background in mind, let us look at newer imaging techniques that might help us improve our diagnostic acumen. Starting with the CT-based techniques, we have dual energy CT. The principle of this is that we acquire images using two energy levels, and this will help us differentiate tissues based on their attenuation differences. And we also get something called as an iodine map. So the iodine map basically tells us the iodine content in a tissue after giving iodinated contrast. So the cancer, pancreatic carcinoma being hypovascular, will show low iodine content. This is an example where we have acquired CTs at two energy levels. This is the iodine map, and we can
recording in progress.
And we can clearly see this region of low iodine content in the uncinate process of pancreas that is suspicious for malignancy. Next, in CT, we have another technique called perfusion CT. What we do here is that after giving contrast, we take serial CT examinations and to evaluate the tumor vascular physiology. And we can also quantitatively measure using parameters such as blood flow, blood volume, and mean transit time. So in this example, pancreatic tumor being hypovascular will show reduced perfusion compared to the rest of the pancreas. And also the blood flow, blood volume, and other flow related parameters in the tumor will be lower compared to normal pancreas and also inflammatory tissue. Now both these techniques have a very good sensitivity and specificity of 80 to 90% and therefore have considerable promise in pancreatic imaging. Now let us move on to the MRI based techniques. The most important and useful technique as of now that is also regularly being used is diffusion weighted MRI. So the principle is that normally all tissues demonstrate random Brownian movement of water molecules, and whenever there is pathology, this movement is restricted, and for example in tumor or inflammation, this random movement is restricted and we can detect it using diffusion weighted imaging. And we can also quantitatively measure it using a parameter called ADC. This is apparent diffusion coefficient. So diffusion weighted MRI is useful to evaluate solid tumors as well as cystic lesions to evaluate their solid component. So this is another case example where we can see this lesion in the head of the pancreas, And this is the diffusion weighted image, and we can see that it is of high signal or hyper intense, indicating that the diffusion is restricted. Now this is the corresponding ADC map that I was talking about, where it will be the opposite. It will appear dark, and if we draw regions of interest, we can actually measure the ADC value, which will give us quantitatively the amount of diffusion restriction. And there are numerous studies which have in fact looked at this ADC values of benign and malignant lesions, and all of them have consistently shown that the ADC value of tumors, malignant tumors, is lower compared to benign lesions. And they have in fact proposed multiple cutoffs. And from what we can see here, we can assume that if we use a cutoff of around 1.5, we can probably diagnose malignancy with a sensitivity and specificity of around 80 to 90%. So in routine daily practice, where do we use diffusion weighted imaging? So we use it to identify small, subtle, and like I mentioned, iso-attenuating lesions that are atypical. We can differentiate malignant and benign when there is a diagnostic dilemma. And we can identify subtle metastasis in the liver, the lymph nodes, peritoneum, and also cystic lesions. The mural nodules will be better picked up. And overall, the diagnostic performance of diffusion weighted imaging is superior when compared to conventional MRI alone. Now, this is regular diffusion. Now, there are some advanced diffusion techniques as well, one of which is called diffusion tensor imaging, or DTI. We regularly use this in neuroimaging, and basically it assesses the tissue anisotropy. That means the arrangement of the tissue at a molecular level. So in case of tumors, due to inorderly arrangement at the molecular level, we may be able to pick up on diffusion tensor imaging, like we see the small focus of a precursor pancreatic lesion in this in vivo study. Now DTI is still in the research setup, but does have potential. Moving on to the next MR based technique, this is called secretin enhanced MRCP. Now as you know, secretin stimulates the pancreatic secretion, and it also increases the tone of the sphincter. Therefore the visualization of the ducts will be better, and potential applications are evaluation of IPM and other ductal anomalies. So here in this MRCP, we see this typical double duct sign with cutoff, and therefore we are thinking there's a malignancy. But on secretin enhanced MRCP, we can see that the duct is actually preserved and coursing through the lesion. This is called duct penetrating sign, and this turned out to be a benign stricture related to chronic pancreatitis. Moving on to the next MR technique, this is another important emerging technique which is used in neuroimaging, which is used in prostatic cancer in the abdomen. This is called dynamic contrast enhanced MRI. Basically, it is a type of a perfusion imaging which analyzes perfusion kinetics. So qualitatively, we can assess the perfusion on different phases, and we can draw time intensity curves. I will come to that in the next slide. And we can also assess quantitative parameters. So we can probably differentiate malignancy from benignity using the enhancement pattern. So this was a tumor in the head of the pancreas, and after dynamic contrast, we've taken this time intensity curve, and this red curve shows the normal pancreas. So the normal pancreas has a rapid uptake of contrast and washout. On the other hand, the tumor shows slow and steady uptake of contrast, which is typical of ductal carcinoma, which is hypovascular but gradually takes up contrast due to its fibrous nature. The next technique is MR elastography, which all of you might be knowing is what is virtual palpation to measure the tissue stiffness. This is already well established in the liver but emerging in pancreas, and shows potential for differentiating pancreatic ductal cancer from autoimmune pancreatitis and even other benign pathologies. So here is an example. This is a ductal adenocarcinoma. This is a mass forming pancreatitis. Imaging, conventional imaging wise, they can appear similar, but if you see the elastography maps, the ductal cancer shows increased color, which indicates that the stiffness is more compared to mass forming pancreatitis. Now, the last MR-based technique I want to talk about is MR spectroscopy. This is a technique where we do metabolic profiling, where the metabolite content of the tissue is assessed by sampling. So, if the elevated level of choline is seen, it means the cell membrane turnover is more, and therefore it is more probably a malignancy. And whereas if the metabolites like creatine, lipids, and N-acetyl aspartate are decreased, it means that the tissue is using more of energy and therefore the metabolites are getting consumed, which also indicates malignancy. Now, MR spectroscopy is regularly used in neuroimaging, and in abdominal imaging we use it for the prostate, but in pancreatic imaging it is in the process of research and shows potential. So, we can see here that all of these MRI based techniques that have spoken about have a fairly good sensitivity and specificity, with diffusion and perfusion based MRI, which are actually available and used in many centers, have sensitivity specificity of around 80 to 90%. So, summary of MR techniques: diffusion and MR perfusion are valuable for identifying malignancy. MR elastography, MRS, secretin, MRCP, these are evolving techniques. They are currently in the research arena but have potential for future clinical application. Next, let us move on to hybrid and molecular techniques. Here I would just like to touch upon PET-CT, which we all know about. So there is FDG PET and gallium-68 DOTA PET for neuroendocrine tumors. So PET-CT on the whole has a very good sensitivity, and regarding pancreatic cancer, when a SUV cutoff of about 2.5 to 3.5 is used, studies have shown that it more suggests that it is a malignancy. So beyond the functional information, beyond the morphological information, it gives us functional information as well. So just to demonstrate, this was a patient who had abdominal pain, jaundice, CA99 level was elevated. Now on regular contrast enhanced multiphase CT, we do not see any hypo-enhancing area in the head of the pancreas, but on PET-CT we can see this area of uptake, and this turned out to be a ductal adenocarcinoma. And compared to conventional imaging, PET-CT has higher sensitivity, higher specificity and accuracy. Lastly, one has to talk about AI and radiomics, which have been making considerable and rapid progress in all areas. So, in simple words, what is radiomics? Radiomics is a quantitative imaging technique where it transforms the images into data. So, the aim is to reveal disease characteristics which are not visible to the naked eye. On the other hand, AI learns patterns directly from the data. Now there is integration of the two techniques, allowing more precision imaging and even predictive imaging. So this is a typical radiomics outflow where multiple data is acquired and curated, and this undergoes radiomic feature extraction. Now numerous features are extracted, and like intensity, shape, texture, vascularity, density, just to name a few. In fact, hundreds of features will be extracted. This will undergo radiomics analysis, and further we can integrate it with clinical information, biological information, and finally develop a predictive model. So when we look at evidence based on literature, the PET and molecular imaging techniques have a very good sensitivity and specificity, and some studies have also shown that radiomics AI outperforms visual interpretation. So to conclude, if we consider it like a diagnostic algorithm, we usually begin with CT as a baseline investigation. If there is ambiguity, MRI with diffusion weighted imaging helps in problem solving. And if the uncertainty still persists, we can do EUS FNAC. Now beyond this, novel imaging techniques like dynamic contrast enhanced MRI, dual energy CT, PET-CT, along with emerging tools like AI and radiomics are gradually enhancing our diagnostic accuracy. So finally, to conclude, I would like to say that novel imaging techniques in all areas of imaging enhance and improve our diagnostic accuracy. They actually combine anatomical information with functional data and also quantitative data, and they have a potential for serving as a problem solving tool in addition to our baseline conventional imaging. With that, I would like to conclude. These are some of the references that I have used for my talk, and thank you for your patient listening.